Hello, my name is Paul Rosenberg. I am a professor in the Department of Endodontics at New York University College of Dentistry. I'm also an author of many articles, chapters, and a new textbook titled Endodontic Pain. I also maintain an endodontic practice in New York. Pain prevention is an important aspect of endodontics, and there are numerous strategies available. I'd like to discuss with you a highly predictable means of preventing pain in appropriate cases. Here are some guidelines to follow and the evidence to support these guidelines. A question is, what is the role of occlusion in exacerbations? We will be discussing an evidence-based preemptive strategy. The first thing we looked at was a number of different considerations clinically concerning the patient. We looked at pulp vitality, percussion sensitivity, periradicular radiolucency, presence or absence, the presence of preoperative pain, swelling, stoma, and a history of bruxism. These conditions are all important in terms of trying to categorize cases. Prior to 1998, when this study was done, many people asked the question of yes or no, does occlusion reduction help? And I feel that that is not an appropriate way to formulate that question. Another way of looking at it might be, under what conditions might occlusal reduction be important? Our goal was to look at numbers of different variables and try to categorize teeth in order to develop almost a menu for the doctor so the doctor would have indications of when occlusal reduction was of value and when it was not. Here's what we did. The clinical procedure included three groups. Some groups had occlusal reduction done. Others had simulated reduction. The occlusal reduction meant that the occlusal surface of the tooth was taken out of contact in centric and lateral excursions. The simulated reduction was done in order to act as a placebo. It allowed us to be sure that the patient simply was not reacting to manipulation, but actually reacting to the reduction of the occlusion. In the simulated reduction, we ran a burr against the buccal surface of the tooth so that the patient would have the experience of a handpiece and burr running in their mouth, and yet the occlusion actually remained unchanged. Finally, the control was a group that had instrumentation done, but no alteration of the occlusion. There are three categories demonstrated here, and the patients received surveys which they filled out and responded saying that they either had no pain, moderate pain, or severe pain, and the definitions using very simple language that we used for the patients, and you will see the descriptors and can read them. The no pain group meant simply no pain or sensitivity. The moderate pain group did have some disturbance, but with the use of analgesics, the pain could be held under control. The severe pain group was different. The pain disturbed work or their sleep, and analgesics had little or no effect. Those were our three classifications. We then took over 100 patients and then collected data and did our statistical evaluation. I will not go through all the evaluations, just a few key ones to give you a feeling for what we saw. On to your left, you will see that tall bar reading almost as a very dark blue color. And what it indicates is that in the 66 teeth we studied that at vital pulps, 80% of them had no postoperative pain if we reduced the occlusion. The placebo had just over 30% and the control only 20%. Now shift your view far to the right and you will see under the severe pain category, not one patient who had occlusal reduction reported severe pain. That's a very significant finding, and so this was one that was certainly going to go on our checklist and say vital pulps, that's an important indicator for reducing occlusion when treating vital teeth irreversible pulpitis. The next category we looked at was non-vital teeth. And here we looked at 51 teeth, but there's quite a difference, isn't there? Look to the left and you will see that the placebo and the total reduction were virtually the same. This was an indication that non-vital teeth would not be on our list of indicators for occlusal reduction. Now, true, there are some non-vital teeth that become acutely painful, and then occlusal reduction does become an option, but not as a preventative strategy, but just part of a total strategy. But for our purposes, it's safe to say that at this stage, we have one indicator, and that is a vital pulp. I'll show you a few more so you can get a feeling of this. Percussion sensitive. Extremely important as an item to have and look at and consider biologically in terms of an indicator for reducing occlusion. If your patient reports percussion sensitivity, please remember that that means the periodontal membrane is inflamed. If you want that patient to be comfortable, even after root canal therapy and medication, you still will need to do occlusal reduction. So that is our second strong indicator. The study went on, and we looked at other significant conditions, and in total we came up with 4 conditions, each one of which was an indicator to reduce the occlusion: preoperative pain, pulp vitality, percussion sensitivity, and the absence of a periradicular radiolucency. The next question we asked ourselves was, well, if each one of those was a predictor, how many of our patients in the study had all 4 of those conditions? When we went through the data, what we found was there were 27 patients that had each of those 4 conditions indicating the need for occlusal reduction. So we looked at them, and look what we found. 75% of the group of patients most likely to have postoperative pain had no pain if the occlusion was reduced. And swing over to the right, and you will notice not one of those patients most likely to have pain experienced severe pain. Unless there is a new crown present, which would require fabrication of a new restoration, reduction of the occlusion is a valuable pain preventive strategy in cases with any of the following indicators: a vital tooth, sensitivity to percussion, a tooth with a history of preoperative pain, and teeth without a periapical radiolucency. Classic research has validated these findings. I hope that you will find this strategy useful in your practice. Thank you and good luck.